So the clavicle, instead of being in its elevated and retracted position, is now depressed and protracted. So the upper trapezius muscle is not holding it in elevation anymore. So what happens here is that we spoke about the intraclavicular ligament that essentially stabilizes the two clavicles together. If upper trapezius is not holding clavicle in its elevated position, the interclavicular ligament is most likely going to be strained. Also, possibly, if it's a big strain of the sternoclavicular joint, what's going to happen is a strain of costoclavicular ligament as well, because it prevents the superior glide of the sternoclavicular joint. Now, sternoclavicular joint will also be in dysfunction because the proximal clavicle will glide superior. It's no longer going to sit in its nice and inferior position in relationship to manubrium. The superior capsule of the sternoclavicular joint will most likely be strained together with the intraclavicular ligament. Now, on the lateral end of the clavicle is being depressed. We spoke about it last time. I mentioned it to you guys. When the clavicle sits in a depressed position, it starts compressing on anything that's below it, which is subclavian artery, subclavian vein, brachial plexus, etc., etc. So all these structures will essentially be compressed and may essentially lead to neuralgia or paresthesia in the fingers and hands. Now, the third joint that we're going to examine is glenohumeral joint. Glenohumeral joint is suffering as well from this. Why? Because we spoke about the scapula serving as a table, as a support, because it's in upwardly rotated position. Where's the camera? Because it's in upwardly rotated position, it serves as a shelf for the humerus to sit on. If we get rid of this passive stability and all of a sudden scapula is downwardly rotated, the humerus will have no passive stability from the scapula. So what it's going to rely on is the passive stability from other structures or active stabilizers. So it's going to start relying on the superior capsule of the glenohumeral joint, superior ligaments or middle glenohumeral ligament. So all these ligaments will essentially be sprained. And then the second example here, second female, is knuckles polio. She's actually our typical patient, which you're going to see in the clinic, probably 90% of the time. So the biggest difference is that obviously it's not as severe as in case one, but we also have a lot of strain that's happening through the acromioclavicular and scapulothoracic and SC joint as well. So all the structures that I mentioned in the polio patient will most likely be strained as well, such as interclavicular ligament, the capsule of the superior capsule of the SC joint. The AC joint will be dysfunctional. Of course, you can see the scapula here is very much downwardly rotated and protracted, okay? So you will have tightness in the anterior chest musculature, such as pectoralis minor, will probably be tight. And the posterior musculature will probably be overstretched because the distance between the vertebrae and the medial scapular border is going to be more because the middle chop is not retracting the scapula's back.